Hello, my name's Florence. Welcome to the theobspod. I'm an NHS obstetrician, hoping to share some thoughts and experiences about my working life. Perhaps you enjoy Call the Midwife, maybe birth fascinates you, or you're simply curious about what exactly an obstetrician is. You might be pregnant and preparing for birth. Perhaps you work in maternity and want to know what makes your obstetric colleagues tick, or you want some fresh ideas and inspiration. Whichever of these is the case, and for that matter, anyone else that's interested, the theobspod is for you. Episode 42. Assisted vaginal birth, sometimes called instrumental birth. This feels like an important topic we need to talk about. It seems that antenatal education on this is quite poor. Women come to me often with a vision of a very straightforward birth with minimal intervention, or a caesarean birth with not much in between. But when we look at the statistics, the National Maternal Perinatal Audit tells us that assisted vaginal birth is fairly stable at around 13%. Approximately 7% of these births are using forceps and 6% using Von-2's suction cup. Up to a quarter of women having their first baby may end up having an assisted vaginal birth. The figure is much lower for second time or subsequent babies, sitting at 5%. Why aren't we informing and preparing women better? I know from my own experience running a birth options clinic that the small amount women do know about assisted vaginal birth often makes them frightened. They may have heard horror stories of tears, trauma to both women and babies. And sometimes they come stipulating that they absolutely do not want an assisted vaginal birth in any event. I think there's a lot we can do to educate ourselves and educate the women we care for. To write this episode, I put out a question on Twitter to see what people most wanted me to discuss. And I got a multitude of answers. So it definitely feels like a topic where there's a lot we need to tackle. One of the first questions that cropped up is, let's think about what we can do to prevent assisted vaginal birth in the first place. And as I've mentioned in other episodes, the first step to reducing intervention is, of course, place of birth. The second step is continuity of care. Knowing the midwife and the midwife knowing the woman has shown to reduce assisted vaginal birth. So when we look at reducing intervention, these key factors in how the maternity service is set up, making sure we're offering women home birth and birth in midwifery-led settings, and with midwives that they know, is the first important step. Then, of course, we come on to factors in labour. To understand assisted vaginal birth, we need to build on what I talked about in episode 6. We need to understand the journey that the baby takes through the pelvis. Part of the way the baby travels is determined by the shape of the pelvis itself. The baby enters the pelvis at the pelvic inlet. At this point, the biggest diameter of the pelvis is transverse, and that means that the baby enters the inlet in a transverse direction, i.e. the baby is looking sideways with its back towards either the right or the left side of the mother. As the baby travels through the pelvis, it rotates from this sideways position or transverse position, sometimes called occipito-transverse. It rotates partly due to the shape of the pelvis and partly due to the muscles of the pelvic floor. It rotates and comes through the narrowest point of the pelvic outlet, the ischial spines. These are bony prominences on the side of the pelvis. And usually by this point, the baby's head has rotated. The baby's back is now at the front. It's in the occipito-anterior position. Understanding the inlet, the mid-cavity and the outlet of the pelvis are crucial to understanding the progress of labour, the descent of the head, and therefore understanding assisted vaginal birth and what we can do to prevent it or perform it properly. There is a wonderful midwife who specialises in biomechanics. That is teaching midwives and doctors to understand the diameters of the pelvis and to position women during labour and do exercises during labour to try and maximise and improve that journey of the baby through the inlet, mid-cavity and outlet to aid the rotation that the baby needs to do. I cannot pretend to be an expert in biomechanics. I'm certainly not. But I know that many of the midwives where I work have recently done training in this. And if we find that the baby is in a difficult position during labour, we will employ these techniques to try and do the absolute maximum we can to get the baby to rotate correctly, to minimise the so-called malposition, bad position of the baby, before the baby's head has descended incorrectly, so that we minimise the chance of needing to intervene and maximise the chance of straightforward birth. Working with the woman's pelvis and with the baby is obviously key in trying to prevent the intervention that we might later need to perform. Now let's think a bit about the reasons. Why would we need to perform an assisted vaginal birth? An assisted vaginal birth ideally is mimicking spontaneous vaginal birth. So the only reason to perform it is because you need to speed things up. Speeding things up comes for two reasons. Either you're concerned about the well-being of the baby or the mother. Perhaps that might be the baby's distressed, or the woman's developed a temperature, is unwell, or the reason is that things are going very slowly. And you might argue that actually prolonged second stage, or a long time from being fully dilated to the baby being born, is not necessarily a reason to intervene. But you have to remember, as obstetricians and gynecologists, we've got one eye on now and one eye on the future. Having a very long second stage where the baby's head is pressing down on the woman's pelvic floor and bladder can cause complications for the woman's health in her future. Can mean that pelvic floor weakness, prolapse, and problems controlling her bladder and bowel are more likely. So whilst we want to refrain from intervening, we also don't want to stand back and allow a very long time in labour that might cause future damage. As I said in episode 6, everything is a balance. Common reason for the descent of the baby to take a long time is malposition. So what I've just talked about, the baby's head either not rotating correctly or being in a back-to-back position and not rotating from that. So a baby looking sideways or back-to-back is a common reason why spontaneous vaginal birth doesn't happen and we end up needing to intervene. Because of our concerns about the well-being of the mother and the baby, both immediate and longer term, we set some time frames for pushing. And over the course of my career, these have changed quite significantly. Particularly if a woman has an epidural, we know we need to leave a longer time for the baby's head to descend. Women without an epidural will know when they need to push. As the baby's head hits the pelvic floor muscles, that's what gives them that really strong urge to push. There's a complete change in her behaviour, and we start to hear what we call involuntary pushing. She's not consciously pushing, her body is directing her to work with what's happening within it. And she starts to push because the baby's head is low, ready to be born in the right position. With an epidural, it's not so straightforward. Women do not experience that natural urge in the same way because we've taken some of the sensation away with our epidural. So when a woman is fully dilated but has an epidural, we will often wait 2 hours from that point before any pushing happens, because we want the baby's head to descend and rotate and come very, very low into the pelvic outlet. We know that if we give this time, we will be less likely to need to perform an assisted vaginal birth. And over the course of my career, this has changed. 2 hours is new. We didn't used to wait that long. And if a woman pushed for an hour and the baby's head was not visible, we used to go and intervene. Whereas now, if we think the baby is rotating and making its way down, we won't intervene if everything is fine with the baby's heartbeat and fine with the mother. So patience is really important. The other things that are important in the second stage of labour are bladder care, keeping the woman's bladder empty and thinking about what position the woman is in. Lying flat on her back is not a good idea. So often, if women have heavy legs from an epidural, we're asking them to lie on their sides or sit quite upright. And obviously, if the woman doesn't have an epidural, she can be up and about, she can squat, she can be in all fours. There are all sorts of different positions, and she can work with what her body's doing and how her pelvis is directing her to work. Often women will instinctively do what their body needs them to do if we don't interfere. Okay, let's now say that unfortunately all the things we've done have still meant we're in a situation where we need to think about an assisted vaginal birth. The first thing we need to do is assess. That means examining the woman and decide what we're doing. What are we assessing? So there's a nice mnemonic for this from the Royal College of Obstetricians and Gynecologists. We're assessing F, full dilatation. O, that means no fifths palpable, or a maximum of 1/5 palpable. That means the head is deeply engaged. The head is within the pelvis, and there's very little of it that we can feel in the woman's abdomen. That tells us the head is nice and low. R, ruptured membranes. The waters have broken. C, contractions are adequate, and she's consented. She agrees with the treatment that we're recommending. E, empty bladder. Very important for the bladder to be empty before the baby's head comes past. P, presentation and position known. So that means we know what position is the head in. Remember, we talked about back to back, transverse and anterior. And then S, station. Spines. Remember those ischial spines that I said in the narrowest point of the outlet? So the head should be either level with the spines or below it. And the final S is for satisfactory pain relief. So that makes an acronym, forceps. And there's a very nice, clear, easy tutorial on the RCOG website for junior doctors to learn about instrumental birth. And it appears to be open access when I checked it. And there are some useful diagrams about how the pelvis is and how the baby's head descends through the pelvis. that are well worth looking at if you want to understand a bit more. So essentially, it's very important for us to know exactly what position the baby's head is in and where it is in the pelvis. So we're only going to attempt an assisted vaginal birth if the head is deep down in the woman's pelvis, either what we call an outlet or lift out birth, or mid-cavity, that the head is part of the way through the pelvis and we're going to bring it down and out. How do we check what position the baby's head is in? Well, I've mentioned before that the baby's head is made up of different bones, which are not joined together, and we need to feel the sutures, the gaps between those bones, and what we call the fontanelles, which are two particular gaps between the bones. There's the anterior fontanelle, which is shaped a little bit like a diamond because it has 4 sutures running off it, and the posterior fontanelle, which is like a triangle because it has 3 sutures running off it. These are soft spots on the top of the baby's head. Sometimes in labour, because the baby's head has been squashed and shaped and pushed down the woman's birth canal, it can be difficult to feel these soft spots and know accurately which way round the baby is. In this situation, there are other cues we can use. We can feel round the side of the baby's head and start to feel the ears. Where are the ears and which way are they facing? We can also use ultrasound scan to scan and decide the position of the baby's head that way. That can be difficult because the woman's pelvis casts a shadow and it can be a little bit difficult to interpret the images we see. The other thing we can do is feel the shape of the baby's head. It's often possible to feel the shape of the back of the head versus the front and the brow. Babies' heads can become very cone-shaped, elongated, where they've been trying to push down the birth canal. Babies are very resilient. Their head changes shape immensely in the first few hours and days of life. So when we're examining and assessing to decide about assisted vaginal birth, one of the questions we're asking is this safe to do in the room, in the birth room where the woman is, or is this a situation in which we think that this birth should take place in the operating theatre? If it is that the head is very low, so it's below the spines, so it's what we think of as an outlet birth, then we're likely to say we're going to do it in the room. There's a very high chance of success. The baby's head has come past the narrowest point of the outlet, and we know that it's very likely that we're going to be able to help this baby come vaginally. If the baby's head is higher up, maybe at the spines and in a malposition, so that we think we're going to need to rotate as part of our delivery, then we are more likely to say we're going to do it in the operating theatre. This is because if we're unable to help the baby birth with instruments, we are going to need to perform a caesarean section. And this leads to some difficult language because this is known quite often as a trial of instrumental or a trial in theatre. It's hard to know how we should best describe this. But I'm conscious when people say we're going for a trial, it may sound very concerning to the woman. She's then asked to sign a consent form that says we're going to attempt an assisted vaginal birth, but if it doesn't work, we're going to do a caesarean section. If you're a pregnant woman listening to this or being asked to sign that consent form, you might say, well, why aren't you just doing a caesarean in the first place? If you're not sure you can get my baby out using instruments, why are you even trying? Let's go back to what I said about the anatomy. The baby's head is at the narrowest point of the pelvic outlet. There's very little of the head abdominally. So the baby's head is deep down in the woman's pelvis and is being pushed down further by her contractions. When we do a caesarean, we are making a cut a couple of fingers above the woman's symphysis. So that is right at the top of the pelvic inlet. So to deliver a baby by caesarean in this situation, we've got to make a cut into the womb, and then put our hand deep down, working against the contractions of the womb to lift the baby back up out of the pelvis where it's been trying to go for many hours, and bring the baby out through the woman's abdomen. Caesarean in this situation can be very difficult. It can be difficult to disimpact that baby's head and bring it up when it's been trying to go down. This can cause trauma, bruising, and even fractures for the baby, as well as significant tearing from the womb and bleeding for the woman. Therefore, although caesarean at this point might seem like a simple answer, it's not that straightforward. So if the baby's head is at the spines, even in a difficult position, it's making its way into the pelvic outlet, and it's better to try and bring it down and continue its journey. The next question is, why wouldn't you perform all assisted vaginal births in theatre? One of the reasons you wouldn't go to theatre all the time is timing. If a baby's in distress and you want to expedite delivery quickly, then actually you can have a baby born within 15 minutes of making a decision if you can do it in the room. Immediately you need to go to theatre, things get more complicated, inevitably. And there have been studies that show that it takes on average 40 to 50 minutes to get a baby out from decision to birth if you take the decision to go to theatre. Equally, if a woman can give birth in the labour room that she's been in, it's a more intimate surrounding. There are less people. It's not moving her at such a critical point in her birth journey. She can have good pain relief in the birth room. We can top up her epidural if she has one. And if she doesn't, we can perform a pudendal block, giving some local anaesthetic to the pudendal nerve, which helps numb the relevant area. If we go to theatre, in general, we top up the epidural, or if she doesn't have an epidural, give a spinal anaesthetic. Choice of pain relief also affects our choice of instruments. So women sometimes say to me, I'll have a ventouse, a suction cup, but I won't have a forceps, or vice versa. And this is difficult. As an obstetrician, part of the decision you're making when you're performing that assessment and examination I mentioned earlier is to decide which instrument is best for the job you want to do. In general, if you're performing a rotational delivery, that is, the baby still needs to rotate from transverse to anterior, then you're going to use a ventouse, a suction cup. There are some rotational forceps, Keelan's forceps, which are still used in some areas of the country, but in general they're used less, and where I work, any rotational birth is a ventouse. If there's a lot of caput, the swelling on top of a baby's head, and the woman can't push well because she's got a spinal anaesthetic making her very numb, then actually forceps are a more suitable instrument. A ventouse cup won't stick well when there's lots of swelling existing on the baby's head, and forceps cupping the baby's head can be better to bring the baby down rather than using a suction cup which keeps popping off. So whilst I understand why women have preferences, it's important to understand that the choice of instrument is also dependent on the situation we're in. Yes, those instruments can cause complications for both mother and baby. The ventouse suction cup tends to cause less trauma and tears for the woman, but can cause more complications such as bad bruising or jaundice in a baby, whereas forceps can cause more tearing and trauma for the woman. But on the whole, apart from a forceps mark on the baby's face, they tend to cause less complications for the baby. The next thing that is important is the placement of those instruments. Part of the reason that assisted vaginal birth gets a bad press is our own fault. How well are we performing them? With a Von Too's suction cup, it's very important that we place the cup on the correct point on the baby's head, known as the flexion point. When the cup is correctly placed, as we pull on the baby's head, progressive pulls will give progressive descent, the baby's head moving towards us, and rotation. Slightly bizarrely, rotation does not occur by us actually rotating the cup, and in fact that can cause more trauma to the baby and must be avoided. No, what causes rotation, remember we're mimicking spontaneous birth, is actually if you pull in the correct direction with the cup on the correct point, the baby's head will rotate itself as it comes down through the pelvic floor muscles. You're just hastening the journey it was already going to take. The direction of pull is important. You're initially pulling at 45-degree angle, following the curve of the pelvis. And then as the baby's head comes under the pubic arch, you start to lift up, bringing the direction of pull through 90 degrees, and the baby's head starts to come up and then crown in exactly the same way as it does with spontaneous vaginal birth. At this point, when the baby's head is starting to crown, is the decision about whether or not to perform an episiotomy, a cut, to make extra space. It's true that cuts are more common with assisted vaginal birth, but it's also true that with a Von Too's, this suction cup, that at that point, if you control the birth carefully, get the woman to pant and breathe, and help the baby's head emerge slowly, sometimes a cut can be avoided. One of the questions I've been asked is, can you take the instrument off at that point? And the answer I would give is, it depends what pain relief the woman has had. Yes, if she's pushing well and isn't too numb, then at that point, yes, you could remove your suction cup. You've brought the baby's head down, and then she could birth her baby with the last few pushes. If, however, you've topped up an epidural or have a spinal anaesthetic, then she's not going to be able to feel sufficiently to birth her baby, and you need to continue with your instrument. Let's turn to forceps for a moment. Why are forceps such a problem? Part of it is how we insert them. They look scary. They're big metal instruments, a bit like a pair of salad servers. They have a pelvic curve and a fetal curve. So they have a curve that cups the baby's head, and they have a pelvic curve that lies along the line of the woman's pelvis. I was taught to insert my forceps blades with a finger and thumb, holding it as if it was a pencil. You should not be putting any pressure on insertion. They should just slip in. Your other hand is protecting the woman's vaginal tissues, the forceps blade sliding between the baby's head and your hand. Once both blades are in position, you check that they lock correctly, and then again, the traction is the same, initially at a 45-degree angle. With this, you have one hand on the forceps pulling towards you, and pressure from the other hand downwards so that you end up at the 45-degree angle. The commonest complication from a forceps birth is a lateral vaginal wall tear, a tear up the side of the vagina. And this occurs usually because the person putting the forceps on has not adequately protected that tissue or has used too much force to apply them. With forceps, it's much more necessary to perform an episiotomy, but a forceps can be a very straightforward and good birth. Some of the information I've seen given about assisted vaginal birth talks about a doctor pulling gently, and I think that's a tricky one. In all honesty, I am not pulling gently. I am a fairly small woman. My upper body strength is significantly less than that of some of my male colleagues. For me, an instrumental birth requires effort, and I'm aware sometimes when I'm performing it that effort can be seen on my face. I may break a sweat. After all, I am wearing a gown, I'm wearing a mask, I'm wearing a hat, and I'm exerting myself. I am not exerting undue force, but it is a physical job. And I think the idea that we're very gently guiding a baby out could be unhelpful when women experience assisted vaginal birth. Their expectations may be wrong. Just as they are exerting themselves in active second stage, pushing their baby or working with their body, we are working hard too. It's teamwork. I always say to women when I'm performing an assisted birth, this is teamwork. You're pushing, I'm pulling and guiding. And I think the reality of that is important to understand. It is safe. I'm pulling in the way that I know works for the baby and the woman, in the way that I'm trained to do, and have performed many births over the years, but it is effort and exertion. There are no two ways about it, and we do women a disservice if we don't explain that properly. Sometimes an assisted vaginal birth can be particularly difficult. When you look at the guidance that's produced on assisted vaginal birth, there are rules about how many pulls we should or shouldn't take, and when we should abandon an assisted vaginal birth and opt instead for a caesarean. When you're in this difficult situation, the thing we're trying to assess is there descent? Is the baby's head coming down with each pull? Is each pull bringing us closer to the birth of the baby's head? If it is, then actually to continue that process is the safest option. However difficult it might be at the time, and however much we're worrying about what we're putting that mother and baby through, we will continue because we know it's potentially the lesser of two evils. If the baby's head is very low, it's in the pelvic outlet. Bringing the head back up at caesarean section at fully dilated can be extremely traumatic for both mother and baby. Abandoning an assisted vaginal birth and knowing when to abandon it is a very difficult decision and takes a lot of experience, but it's not something that is done lightly. There's even evidence now that doing a caesarean section at full dilatation may cause some damage to the cervix and can be linked to an increased risk of preterm birth in the future. So we have to be very careful that we're not doing undue harm if we opt out of assisted vaginal birth and perform instead a caesarean section. And this brings me to another question that I was asked during preparation for this episode. Why are we so keen on instrumental births? Why is it that obstetricians and midwives see them as a good thing when I've discussed trauma and difficulty? Well, the reason is that although there's a very high incidence in first-time mothers, remember that statistic I gave, 25%, Mothers that have had that sort of birth are very likely to have a straightforward birth in the future. Remember, only 5% of women will have an assisted vaginal birth if it's their second or subsequent baby. So a first birth is critical in setting up that woman for how her births are going to be in the future. And so part of the reason that we're keen on helping the baby complete its journey in an assisted vaginal birth is that that will set that woman up to have future, straightforward, uncomplicated births. So not only can a caesarean at this stage of labour be very difficult and give rise to complications immediately in the here and now, it can cause her long-term issues in her future births. So we have to be very mindful of that. A question that generated quite a lot of conversation on Twitter was, what is the right position for us to be performing assisted vaginal birth? At the moment, we do assisted vaginal births in lithotomy. The woman is on her back, her legs are up in stirrups. This is the accepted way of doing things. This is the way all obstetricians and gynecologists are trained. But there is an argument to say that this doesn't work well with the woman's pelvis. Remember the biomechanics I was talking about earlier. As I had a conversation at work with one of our midwives about this, the thought occurred to me, perhaps we need to reimagine assisted vaginal birth. Does it always have to be in lithotomy? No, possibly not. And I've certainly heard of the odd delivery being done by my obstetric colleagues with the woman standing, if they're doing an outlet delivery, perhaps using a suction cup to ease the baby out when the head is very low. But the whole conversation got me thinking. In the same way that we are reimagining breech birth upside down to the traditional way we doctors have been taught, could we reimagine assisted vaginal birth? It would need some thought, because assisted vaginal birth is certainly more common in women that have had an epidural, and therefore their legs are a bit heavy. And so going with what their body's doing and perhaps birthing in all fours or upright is not as easy. Is it time to think again, perhaps with a woman lying on her side in left lateral, allowing more movement of her pelvis and coccyx to accommodate the descent of the baby's head? Food for thought, I think. Now for the zesty bit. My zesty bit this week is, it's our responsibility to educate women properly about assisted vaginal birth, instrumental birth, especially women having their first baby, so that they understand in advance the possibility of this sort of birth. This helps them not only do everything in their power and our power to prevent it becoming necessary, such as using passive descent, waiting for the baby's head to descend before pushing, and use of biomechanics in labour. But it also means that when a woman needs an assisted birth, she understands what will happen, why it will happen, and we can support her through it. As a pregnant woman listening to this, understand that assisted vaginal birth covers a large range of possibilities. Try and prepare yourself in advance. Arm yourself with knowledge. This means that if and when it becomes a possibility, you can ask the relevant questions and understand your choices. Do everything you can to try and minimise the risks, but also understand that an assisted vaginal birth may be a very safe option for you and your baby in the event that it becomes necessary. I do hope you've enjoyed listening to this episode of the theobspod. Feel free to contact me on Twitter at FW Maternity or at theobspod to ask me questions, give me topics for future episodes, or let me know what you think. It's absolutely fantastic when you get in touch. I really enjoy reading your comments. As usual, I've tried to include in the programme notes some extra reading about this particular topic, both for professionals working in maternity care and for pregnant women using services. I'd like to reassure you that although I'm talking about my experiences working in maternity care, I take confidentiality very seriously and do not give any personal information about any of my patients. If you've enjoyed listening, I'd love you to recommend the obstetricians to friends or colleagues, and please do leave me a review on whichever podcast directory you find my episodes. Many thanks for listening.